Good afternoon, everyone. So today we'll discuss a newer mode of ventilation, that is NAVA. So this is the newer mode that is getting popular nowadays. However, majority of the ventilators doesn't have this kind of mode. Only the Getness, Macwit, Servo N and Servo I has the NAVA facilities which need to be special model to be inserted. We thank the Getness Macwit for helping us to understand the NAVA ventilation. So to begin with, the objects of ventilation is what is the use and what is the importance of non-invasive ventilation. Then we'll discuss what is the EDI and the NAVA. How do you want to set up the NAVA and what is the use of this NAVA ventilation in our newborns and pediatric population. Respiratory failure is one of the major important cause for the NSU admissions, and in majority of the centers using non-invasive ventilation as a predominantly mode of ventilation in order to prevent any further damage from the mechanical ventilation. But sometimes the intubation mechanical ventilation is unavailable, then we need to short the duration of the mechanical ventilation. The problems in the units during the non-invasive ventilation is one is because the lung mechanics are different compared to the pediatric and adult population. There are very small airways that can lead to the increase in the airway resistance. There are short time constants, short inspiratory times, and the high respiratory rates. Even the tidal volumes are very small, 4 to 5 ml per kg is the normal tidal volumes of the newborn. So in 1 kg, it may be around 4 ml, which is very small compared to the hundreds of ml in the case of the adults. And the majority of the disease process in the newborns affect the lungs, parenchyma that can lead to the decrease in the complaints, and the premature and the sick neonates have very limited muscle strength. So all these mechanics of the lungs poses a challenge for the introduction of the NAV in the neonate. Not only with these lung mechanics, even with the equipment, the nasal prongs or the masks are sometimes may not be fit properly with the neonate and they may be moving. There can be sometimes, because of inadequate humidification, there can be presence of water humidification in the masks and the tubing that can lead to that can lead to either leak or that can lead to the nasal damage. And they have irregular kind of breathing, they have the periodic breathing, the efforts may not be the great. So it is very difficult to monitor the breathing efforts in the newborn. So these are the various challenges to provide the non-invasive ventilation in these units. But still we need NAV because, as we know, the intubation is very painful procedures, and we need to, in order to decrease the pain, we need to do so many medications, and the ET2 placement in the trachea itself is a painful. So we need to provide some kind of analgesia for these babies, and these analgesia have side effects. And if you're not having adequate assessment of the ventilation, it can lead to accidental hyperventilation, more lung damage. It can lead to more amount of infection because of the poor amount of drainage in the secretions. So by using the NAV, we can lead to decrease in the chance of pain, decrease in the chance of accidental hyperventilation, and decrease the chance of infection inflammation. NAV leads to better sleep because the pain is less and the baby will be better comfortable on the non-invasive. And as studies have clearly shown that NAV lead to shorten the duration of the ventilation time. But still, we don't know which ventilator setting and support is right for the baby because the newborn physics is changing and the disease process will evolve or will improve. So the kind of the proper ventilation is to provide to the baby is always a challenge in the neonatal period. So if you don't provide a proper ventilation, the baby will fight with the ventilator. Then in order to control the baby, we need to over-sedate the baby. The sedation can lead to the neurological damage. The neurological damage again itself will be posing a major challenge in difficulty in weaning and prolonging the mechanical ventilation. So if you sedate, you're not providing the proper ventilation, but just giving the over-sedation, you may under the over-assist the baby. That can lead to the patient and ventilator dysynchrony. That may overtide the baby's efforts. Again, it can lead to the prolonged mechanical ventilation. So all this can affect the baby's quality of sleep. The sleep is important for the baby's nutrition and growth, for the proper digestion of the milk. So if this is there, then again the baby will be weight gain will be there. So all things may lead to the difficulty in weaning and the prolongation of the mechanical ventilation, which itself can lead to the infection, down to the dysplasia, and can lead to further lung damage. So normal what happens is whenever the baby the breathing happens, the impulse is initiated from the central nervous system, so the brainstem, medulla oblongata. So where the respiratory centers are present, so the impulse from the respiratory center will be going to the phrenic nerve. So both right and left phrenic nerve, and these phrenic nerves will innervate the diaphragm, and there will be the excitation of the diaphragm. So the impulse will spread to the diaphragm. Then the diaphragm muscles will get contract. That can lead to the increase in the chest wall space, negative pressure. That can lead to the movement of because of the negative pressure, there will be movement of the air from the outside to the lungs. So there will be a certain flow and there's a certain volume of the air that is being delivered to the lungs. So in the case of a mechanical ventilation or a non-mechanical ventilations, we want to synchronize the kind of the breath that is being provided by the ventilator. So in the conventionally, we use the flow sensors, whether either flow sensor can detect the based upon the flow, or they can be pneumatachometers where the defects of the pressure. So based upon the pressure changes or based upon the flow at the level of the flow sensors, the ventilator will detect the negative flow of the pressure changes, and the flow sensor will just transmit the impulse that the baby want to breathe, and this impulse will go to the ventilator unit, and the ventilator will develop will give the breath. So a bit higher, we can use the Gresby capsules where it detects the chest wall and the lung expansion, and from here also the impulse can be transmitted to the Gresby capsule ventilator unit, and the ventilator will know that the baby want to take the breath, and the ventilator will deliver the breath. But the problem here is there's so much of time delay between your central nervous systems and the time the baby and by the time the flow sensors or the Gresby capsule will detect the respiratory impulse. So ideally what happens from the central nervous system, the phrenic nerve, the diaphragmatic excitation will happen, diaphragmatic contract at the same time, the breath need to be delivered. So here comes the role of the NAVA. So the NAVA, rather than waiting for the impulse to transmit till the airway, as soon as the diaphragm get excited, the impulse will be transmitted through the NAVA catheter, EDA catheter to the ventilator, and the ventilator will give the breath. So in this way, we are bypassing all these things, and we are probably maybe at the correct time we can identify the diaphragmatic excitation, which is actually the impulse that the brain is sending in order to provide the proper ventilation. So here the plays the NAVA major role. That's why this kind of the ventilation has been developed. So in a case of a conventional ventilatory system, either NAV or either case of a mechanical ventilation, we need to set a few things. So we need to set a trigger which is sensed by the flow sensor, the pressure or the flow trigger. Then the ventilator when the ventilator will start giving the breath, and we need to provide optimal pressure support level. And then after a certain time, then cycling should happen from the inspiration to the expiration. The problems in a case of a pressure support ventilation is regarding the trigger, if you set too high level of sensitivity, there will be so much of auto triggering happens. If you set too low level of the sensitivity, so then there will be so much of wasted effort. So in this way, either we can over trigger or whether our trigger is not actually picked up by the ventilator. So we may not be knowing what is optimal trigger. And regarding the pressure support level, if you put too high amount of support to the baby, you can lead to over ventilate the baby, and that can lead to lung damage. If you keep very low support level, that can lead to the inadequate ventilation, that can lead to hypoventilation. And regarding the cycling, so majority of the time we are using the time cycling. So after a certain point, maybe around 0.35 or 0.45 of the inspiratory time, we are asking the ventilator to cycle off. But we don't know whether the baby is still in the inspiratory phase, or whether the baby want a very short inspiratory time and want to shift out to the expiratory time. So here the synchrony will be again the problem. To cover this one, there are certain flow sensing will be a major advantage here, but there are certain problems even with the flow sensing, because we are sensing at the level where it is happening at the level of the airway, not at the level of the brain impulse to the diaphragm. So to overcome this, they have developed the NAVA and the EDA. So what is EDA? So EDA is the electrical diaphragmatic activity. So as we've seen, the impulse from the brain will go to the phrenic nerve to the diaphragm. Here, the EDA catheter will detect the signal, and from there it will transmit to the EDA catheter and EDA cable to the NAVA machine, where the module where it assists and provide the EDA signal. So EDA is basically the waveform represents the neural initiation of the breathing, that is the output of the respiratory center, which moves down the phrenic nerves and literally activates the diaphragm. The simple way EDA is what the patient's respiratory rate that is coming from the brain, and we measure the EDA in the microvolts. So normally the EDA catheter is just like a feeding tube catheter that has some 9 electrodes which are present outside the catheter. I will show the EDA catheter in the subsequent slides. And we can use this EDA catheter, which is actually nasogastric or orogastric tube, along with having the electrodes, and we can use this for the feeding purpose. So the signal that diagnosed by the EDA is similar to the signal like an ECG. So we'll show the EDA signal. So the EDA catheter will detect both the EDA signal, which represents the diaphragmatic activity, the diaphragmatic signal capacity, and also it can detect the ECG, and both of these will be detected by the EDA, and we'll see why it is important. So the problem with the routine ventilation thing is we miss so much of synchrony. The various ways where the synchrony is being not able to provide it in the case of the ventilation, even though we use the flow sensor. So one is here we can see that. So this is an EDA. We'll discuss what is the graphs in the EDA, what each EDA wave will tell us. So first the thing is, so to briefly, this is an EDA, so where you can see that there is an electrical wave is present at the case of the diaphragm, and there is a impulse has been generated. However, this impulse that is present at the level of the diaphragm might still not yet gone through the airway level. So your routine flow sensors will not detect this electrical activity. They are waiting for the flow sensor to wait for the changes in the pressure or the flow. So we are missing this respiratory effort. So this respiratory effort from our brain is wasted. The next thing is an auto triggering. Here we can see that there is no idea. So the brain doesn't want to breathe, but the ventilator is providing the breath. This happens usually because of auto triggering. The auto triggering can happen because of there is certain leaks of the flow sensor, or there is certain because of there is certain amount of the condensation that has happened in the flow sensor, which flashily trigger your ventilator to provide the breath. That can lead to overventilation, and then maybe can develop hypocapnia. The next thing is there is a delay in the trigger. First one we have missed completely. The second one is we are unnecessarily giving the breath. Here we are delaying actually triggering the ventilator. So the brain want to start the ventilation. Right? It has provided the impulse, and this impulse has want the baby to start the breathing. However, there is a delay because the impulse, even though the diaphragmatic has been contracted, we are waiting for the flows to change. So there is a delay is happening here. The ventilator will start delivering after the baby want the respiratory effect. So there is a delay in the triggering is happening. And here we can see that in the EDI, there is a cycling from the inspiration to the expiration. So the baby want to actually, according to the brain want, does not mean baby, the brain want to go to the from phase of the inspiration to the expiration. But as we have said, a TA of maybe or it's a 0.35, 0.45, which usually sets for normally for based upon the disease process. But this baby's brain doesn't want to have this kind of prolonged inspiration. But we are providing the prolonged inspiration to the baby. This can lead to the asynchrony in the baby. The last final thing is here we can see that the baby want to have a prolonged breath. Even though we might have set a 0.3 or 0.4, the baby might be requiring 0.45, 0.5. But as we have set the ventilator to 0.3, even though baby want to be breathing, want to have some more amount of the inspiratory time. As we have said, the inspiratory time short, the ventilator is switching off from the inspiratory to the expiratory. So there is a premature inspiration. So in this way, there are 5 different kinds of the synchrony is being missed. So in order to have better synchrony, the NAVA will help to identify the signal at the level of the EDA so that the better synchrony can happen. So here comes the importance of the NAVA. So the NAVA is a neurally adjusted ventilatory assist, and the non-invasive NAVA is non-invasive neurally adjusted ventilatory assist. These are the innovative modes of neural triggered ventilation, where they actually uses the electrical activity of the diaphragm by means of the EDA catheter, and which help us to trigger the mechanical breath from the ventilator. Overall, based upon this activity, the synchronization to the baby will be best with the ventilator, and we can avoid so many various ways of the asynchrony. So the NAVA and the NAV NAVA thus can serve as a potential solution for the difficult synchrony in the ventilating premature infants. So EDI is electrical diaphragmatic activity. So we need to measure the electric diaphragm activity, which is more like an ECG kind of things for the heart. The diaphragm is the heart for the baby. So we measure the EDI activity and will continuously monitor the EDI activity. Based upon the EDI activity, our ventilator will provide the breath. So when you see the EDI characteristics of the EDI signal, so this is the EDI wave that's present in the macro. So the components of this EDI signal is, we can see various waves that are seen. So this is EDI signal. So the first thing is there is an upward deflection in the EDI wave. So there is upward deflection in the EDI wave. This is the neural inspiration. So your brain want to inspire by sending the signal at this point of the time. So this is the EDI peak. The EDI peak is the maximum the EDI signal that is present from, that is being generated from the brain. The next thing is a downward deflection. You can see there's a downward deflection of the EDI waveform. The neural downward reflection is a neural expiration. So our brain want to expire at this phase by stopping the inspiration. And we can see this lowest value during the expiration. This is called as the EDI mean. The next thing is a neural inspiratory time. The neural inspiratory time is the time period from the starting of the inspiratory neural inspiration to the peak of the EDA signal. So this is from the start of your EDA neural inspiration and to the EDA peak. This is called as neural inspiratory time. The neural expiratory time is the time when the brain want to keep the baby in the expiratory phase, is the time from the peak EDA till to the start of the next increase in the EDA. This is called as the neural expiratory time. So in a case of the EDA signal, so these are the various waves. This is inspiratory, this is expiratory, this is EDA max, EDA min, and this is inspiratory phase, and this is the expiratory neural expiratory time. And we can see the EDA peak and EDA minimum, that is value will be depicted in our the screen when you select the EDA module. So NAVA, actually this NAVA will identify this EDA signal from the time to time, and it will help in the assessment available, and it will help to take this EDA signal. Based upon the EDA signal, it will assist the baby to provide the ventilation. So NAVA delivers assistance in proportion to, and along with the main thing is synchrony with the patient's respiratory effect based upon the electrical diaphragmatic activity. It is neurally integrated with the lung protective reflex so that it prevents overinflation or underinflation that follow the hair brain reflex. So in NAVA, the breath support is controlled by the patient needs and demand. So only when the brain sends a respiratory impulse, then only your breath will be supported. Both the NAVA and the NAV delivers ventilator assist in proportion and in the synchrony with the patient's EDA signal. So everything is based upon the EDA signal, not based upon the flow sensor. So we'll be identifying early, we'll have better synchrony, and we'll know the what amount of the ventilatory support that is needed based upon the needs from the brain rather than from the flow. So the EDA catheter itself can be used in three ways. One, it can be used in the NAVA, where it's an invasive ventilation, where it helps, as we discussed, it provides a synchronization. So based upon the signal, it will know when to start the inspiration, when to start the expiration, what is the peak thing. And when the baby, suppose the patient is in sedation, based upon the signal that is being generated at the diaphragm, it can help it based upon the EDA max. We can know what amount of the sedation that we can provide the baby so that we can avoid over and we can avoid the under sedation. In the case of NAVA, it provides a better synchronization similar to the NAVA. However, here, as we don't have any flow sensors at the time of the nasal mask or the nasal airway, it will entirely the triggering based upon the EDA signal. So it is independent of the leakage, and we can deliver an appropriate tidal volume based upon the signal intensity from the brain. The last is EDA monitoring. We can use just like EDM or the EDA catheter can just monitor the respiratory status based upon the EDA signal, and we can know how much strength of the EDA signal. Based upon this, we can assess the respiratory efforts of the baby. So the NAVA actually, the NAVA delivers the tidal volume that what the patients want. Suppose in the case of the healthy baby, we want to deliver a proper tidal volume. We need, suppose this baby want a tidal volume of 5 ml. So this 5 ml tidal volume will be provided in all the things. Suppose in a healthy baby, your muscle will be in a good state, the lungs will be in a good state. So your brain would need some normal kind of the impulse, where the impulse will be a bit normal. So you don't have a very high signal intensity here. So as the disease process is worsening because of the lungs are getting damaged, the patient need to get more amount of the respiratory effort. As the ventilation oxygen is not happening to the brain try to produce more amount of the respiratory effort. This can be depicted by the high EDA signal. So based upon these EDA signal, then your NAVA ventilation will adjust this kind of the assist that is required, and based upon that, we'll provide a proper kind of the assist that baby actually need rather than what we feel. So NAVA actually delivers what the tidal volume, what the patient wants. The efficacy of the respiratory muscle determines the degree of the respiratory center's output. See what does it mean that? So if you have, as we discussed earlier, if the baby's respiratory system is good, muscles are good, then the baby doesn't require very high respiratory impulse. So your EDA will be low. With any disease state, as the baby brain want a better oxygenation ventilation, it want to provide the sufficient amount of the respiratory effort is not being generated and your ventilation is not being done properly, then your brain want a better kind of ventilation. So the respiratory effort need to be increased. In this case, the impulse strength from the brain will be more, so the EDA signal will increase. So what are the way EDA signal will varies based upon the thing, and based upon the EDA signal, the ventilator will provide the respiratory assistance. Ultimately, your tidal volume will be maintained in the set range. So in the disease when the muscle may not be performing efficiently, then there is increase in the respiratory center signal, and therefore the more amount of the additional muscle fibers from the diaphragm will be recruited. So in order to make more discomfort to the baby, here based upon this kind of the signal, the ventilator will take up the proportion of the work of the breathing and support the baby, so that the baby work of breathing will decrease. So how to set NAVA? So the NAVA will be set based upon this process. We'll discuss one by one in the subsequent slides. So first we have a backward ventilator servo in a survey. So where it has a special EDA module is there. So the EDA module should be inserted into the cable and into the slot, and then the EDA cable should be attached. So the EDA module is fixed and the EDA cable is inserted to this. Then the ventilator starts showing the EDA mode, EDA with NAVA mode of ventilation will be highlighted in the ventilator. Then we need to select an appropriate EDA catheter. So the EDA catheter, as we've seen here, is just like a feeding tube, but it consists of the electrodes at the distal part of it, and one is for the feeding and one is for the EDA cable that is attaching to the EDA cable, and there is a EDA cable that will be attached to here. So the EDA catheter is just used for a single use only. The problem with this NAVA is the EDA catheter is costly, and the EDA catheter may be maximum use for the 5 days. After the 5 days, we need to replace it. This is only for a single use. So based upon the weight and based upon the height, they have the different kinds of a catheter. For a usual, as a neonatologist, we use the preterm babies. We use usually 6 French or 49 to 50 centimeters, because of majority of the babies may be around 1 to 2 kgs. In the case of a term baby, we can use at 8 French, either 50 or 100 centimeters. So we don't go beyond that because our babies are small. So once you have select the EDA catheter appropriate size, then we need to know how far we need to insert it into the esophagus. So for this, there's a formula. So there's a next. Next is the distance between the nose, ear, and the axis. So here is the nose, N, E is the esophagus, and X is the, so E is the ear, from the nose bridge to the ear, from the ear lobule and then to the xiphoid. So based upon this length, here we have a Y centimeter corresponding things. So based upon the what, well, suppose you get a value of around 54, we need to insert in 67 centimeters on the EDA catheter. So based on that, we can sorry for the inconvenience. This is a small technical error that's happened. So once we have inserted the EDA catheter, we need to see whether the EDA catheter position is in place or not. So ideally, when you have inserted the EDA catheter and select the NAVA mode, there will be EDA signal and there will also be the ECG waves. So there are 4 ECG waves are present in the 4 leads. So ideally, when you properly inserted, the P wave should be present only in the first 2 leads. And slowly as we go down, then third and fourth, the P wave should not be there. Then if you correctly position the EDA catheter, the second and the third leads will be in a pink color. So when the second and third in the pink color, it suggests that the EDA catheter is in correct position. So here the second and third are normal, so your EDA catheter is in the correct position. If the first and second leads are pink, it means that your EDA catheter is inserted deep and we need to the pull. So here we have seen that the EDA catheter is inserted deep, so the distal part of the things, I mean the topmost of the electrodes have been identified the ECG. So the top 2 leads are been having the pink phase. So it means that you have inserted too deep and we need to slowly pull the EDA catheter till the second and third waves are in the pink color, like this. Suppose if your third and the fourth ECG leads are in pink color, it means that you have inserted EDA catheter shallow. So we need to insert further. So once you insert the further deep and it shows the turning of the ECG leads with the pink waves are coming from the third to fourth to again to second and third. So here from third to fourth, when we have inserted too deep, then it comes to second to third. So in this way, we can know that whether the EDA catheter is properly placed or not. Sometimes we don't find any signal in the EDA. So even there is no signal in the EDA, it can be because you have oversedated the patient. So the respiratory center is also sedated high and therefore is no electrical impulse from the brain respiratory centers. And sometimes we have over-assisted the baby so that there is no need for the respiratory center to give any stimulus because the ventilators are completely taken off the ventilatory part of the baby. It's completely assisting. So we are over-assisted the baby, so there is no respiratory type from the baby. Sometimes the EDA catheter may be out of the position, then also there is no EDA signal. But the ECG wave is still present. There can be phrenic nerve injury when the case of a butt asphyxia. There can be any HI. There also we can have a kind of absent EDA signal with the normal ECG waves. We have selected the catheter inserted, properly inserted, and then we need to select the NAVA mode. So in the NAVA mode, basically, as we have discussed, one is the EDA peak and one is the EDA minimum, and after the above the EDA minimum, there is a EDA trigger will be there. So EDA peak reflects what means the EDA peak is, the EDA peak reflects the diaphragm work that has to be performed for each breath. So this is the maximum impulse that the brain will deliver to the diaphragm to make it to work hard for the breath. The EDA minimum is the lowest value that present at the start of the breath or after the breath, is the baseline resting diaphragm contractions, and it shows what is the tone of the diaphragm during the time of non-breathing state. EDA peak is the work of the diaphragm has to perform, and the EDA minimum is the tone of the diaphragm at the in between the diaphragmatic contractions. So what is the assist pressure? The P peak. The P peak is the one that is the maximum pressure that has been delivered to the baby. And in order to calculate, we need to do the NAVA level, and we need to do the EDA peak and the EDA minimum, and we need to have a PEEP. So the formula for the estimated P peak in NAVA is the NAVA level into the difference between the EDA peak minus EDA minimum plus PEEP. So this is the P peak in the NAVA mode of ventilation. It's like maximum P max that NAVA can be delivered, and it depends upon your NAVA level and the respiratory stimulus from the brain and the PEEP that you have been set. So once we have set, we select the mode and we have know this, and then we need to set. Next most important thing is we need to set the NAVA level. So what is NAVA level? So the NAVA level, as per definition, is a factor by which the EDA signal need to be multiplied to adjust the amount of the support that is delivered to the baby. In a simple way, the NAVA level reflects the proportion of the work of breathing that the ventilator have to take over from the patient. If you normal the NAVA level unit is centimeters of water per the millivolts. So what means that the NAVA level, based upon the NAVA level, if you set low or high, this is the amount of the breathing work that the ventilator need to take over from the patient. So this is the amount that the ventilator need to assist the patient and to decrease the work of breathing on the patient. Normally, the NAVA level is set in between 0.5 to 3. We usually need to set 1 for the invasive and 0.5 for non-invasive. And we need to wait a few breaths for the stabilization. So first we'll set a NAVA level around maybe 1, and we see the EDA signal. And based upon the EDA max, we need the EDA max around 10 to 15, and the EDA minimum should be less than 5 microvolts. So till we get this level, we need to adjust the NAVA level. Typically, the NAVA level, as we said, it's between 0.5 to 3. And we use a lower NAVA level in the case of NAVA. As we have seen in the case of non-invasively, we'll provide 0.5 and invasively start with 1. So what we need to do is, we start with, suppose for example of a NAVA of 0.5 or 1. Suppose we start with 1. And then based upon this NAVA level, that means that amount of the assistance has been provided by the ventilator for the breathing. The amount of the breathing at that point of the support, we'll see how much the brain is providing the stimulus for the diaphragm to contract, and based upon this EDA max and the EDA minimum, we'll need to adjust the NAVA level. So how we'll do it? We'll just go into the further slides. So as we've seen in the graph, so the red one will be depicting your biological diaphragm. There's a normal diaphragm that presents the body. The mechanical diaphragm is the ventilator one diaphragm that need to take out the work. So if you set a very low NAVA level, that means that we are assisting the baby very low. So the majority of the work proportion has to be done by the baby itself. So as we slowly increase the NAVA level, the workload on the baby is decreasing, and the workload done by the ventilator is increasing. So very low level, the baby is completely taking the ventilatory work of breathing. Very high, the ventilator is completely taking the work of breathing. So we want a point which called as a breakaway point where it is completely balanced, so that baby should also breathe in order to maintain the muscle activity and not allowing the muscles to get wasted. At the same time, we need to support with our mechanical ventilator so that the work of breathing is not completely superimposed on the baby and the baby will not get tired. So this is the break point. So we'll start the NAVA level slowly, and we'll see the EDA peak. When the EDA peak starts falling to 10 to 15 microvolts per minute, then that is the time, that is the NAVA level that we actually want for the baby. What we'll do is we'll start with some 0.5, we'll slowly increase, And at the point where the EDA peak will start decreasing and falling in the range of 10 to 15 microvolts, that is the NAVA level that we want for the baby, which provides adequate respiratory support to the baby. What happens if NAVA levels is too much increase? So as in conventional ventilation, if you increase what the pressure support, what will happen? The tidal volume will go on increase and happens. There won't be any other corrective measures. However, in the NAVA ventilation, the lucky thing is when you increase the NAVA, so that means we are increasing the respiratory support, taking the more amount of the work of breathing, transiently the tidal volume will increase. But what happens is we are taking the control over the NAVA, we are taking the control of the ventilation by increasing the NAVA level, then slowly the EDA peak will decrease, because as we are taking the so much of ventilatory work of, we are taking the as we are taking a significant proportion of the work of breathing by the ventilation, the brain doesn't need to send any signal impulses, high intensity signal impulse for the diaphragm to function. So when the NAVA levels start increasing, after some time the EDA peak, that is a impulse from the brain, start decreasing. Ultimately it get balanced out and your tidal volume will be maintained in the appropriate range. So this is the way we can see that in the case of a routine pressure support where the tidal volume ventilation will see, if you increase the pressure support, it's not a volume gland ventilation, I'm just telling the normal pressure support. So if you increase the pressures, the tidal volume will increase, and there is no check for the here in the case of a routine. However, in NAVA, when you increase the NAVA level from 0.51 1 to 1.5, there is transient increase in the tidal volume. But as you're overtaking the majority of the work of the breathing, slowly the brain will start decreasing the intensity of the signal. So your EDA max will decrease, and this, so your NAVA level, even though is increased, the EDA max is decreasing. So your overall the tidal volume will be maintained in the appropriate range that you have been set. In contrary to this, in contrary to NAVA level in the pressure support, as we increase the pressure support, the tidal volume will increase, go on increasing as long as the pressure support, and there is no check over it. So this EDA wave, we know that this is the EDA max and this is the EDA minimum. So usually we need to have a trigger, just like it was inside where you kept the 0.2 ml per minute. Like here also we need some trigger. So if your brain is able to trigger this EDA signal of at least usually set around 0.5 above your EDA minimum. So here is the EDA minimum 0.3. You want to set a EDA trigger of around 0.8. So if your brain is able to trigger the diaphragmatic contraction by 0.8 EDA signal, then the ventilator will start providing the breath. So it will provide an inspiratory phase, and when your EDA signal will drop to 70% of the max, then it automatically cycling happens from the inspiratory to the expiratory phase. So in this way, the synchrony will be better, and all kinds of the required trigger that has been triggered by the brain in adequate amount can be used for the providing the ventilation. So there's no wasting of the ventilation, there's no auto triggering, and we can have better cycling compared to all kind of the cycling that we do for a conventional ventilation. There's a check present in order to avoid the excessive volume delivery. So maybe not, we may not even allow a transient increase in the tidal volume. So there will be a pressure limit check, like similar to our volume control ventilation or volume, where we need to keep around 5 centimeter at water of the pressure should be kept above your upper pressure limit. So we calculate the P max based upon the NAVA into EDA max minus EDA min plus P. We need to keep the upper pressure limit around 5 centimeters beyond the P max. This is a checklist which restricts the excess of the volume delivery into the lung and damaging the lung. Even a small or 2 to 3 breaths of high tidal volume can even still trigger the inflammation in the lung and can damage the premature lung. So now we need to ventilate the baby. We need to set the EDA signal. We know the NAVA, we know the P max, and based upon these waves, we can adjust the amount of the ventilation that can be provided to the baby. So if your EDA peak is high, which means that baby is not adequately supported, you are providing an underventilation. So your brain want to take more amount of your baby's brain want to take more amount of work of the breathing. So your EDA peak is high. In order to increase the support, we need to increase the NAVA level. If you have very low EDA peak, that means that you are completely providing more amount of the support from the ventilation. The baby is over supported, so the brain is not producing a EDA peak of high level. So we need to decrease the baby support and we need to decrease the NAVA level. The next important thing is if you have not only this EDA peak and also the EDA minimum is also has an important role, because whenever you have as we have discussed already, the EDA minimum is the amount of the tonic presence, amount of the tonic tone that is present in the diaphragm in between the inspirations. So if you have very high EDA minimum, that means that you are not providing an adequate PEEP and we need to increase the PEEP. If you are having very low EDA mean, that means that the tone is not being required for the diaphragm to maintain that contraction. So we are providing the excessive PEEP from the ventilators in order to decrease the PEEP. So in this way, based upon the EDA waveforms, where we can adjust the NAVA levels, we can adjust the PEEP, and ultimately we know what is the Pmax based upon the formula, and based upon that we can avoid the pressure limit. So in order to prevent a excessive ventilation that happened to the baby. So this is the flow chart that is published by Fang et al. In the an article in the Pediatrics and Neonatology in the 2023. So here we can see we need, first the thing is we have a EDA module, the cable is inserted, then we need to do the catheter preparation. We need to take appropriate catheter, measure the appropriate catheter, rinse it well with water, get activated. Then we need to measure the NAX, that's the nasal bridge, to the ear lobule, to the Ziphod sternum. And based upon the Y value, we need to insert and we'll check the catheter placement based upon the pink curves and based upon the P waves. And we'll adjust to keep it the pink waves in the middle, second and the third. And then we'll begin the NAVA setting. We'll start with the NAVA level, say the 0.5 centimeters for the NAVA, for the 1 centimeters, for 0.5 to 1 centimeters for the NAVA, or a 0.5 centimeters for the NAV NAVA, and slowly we'll increase the NAVA levels by 0.5 until we reach the break point. The break point is where your EDA peaks starts showing a downward trend and will ultimately be in the range of 10 to 15. So this is the break point where the ventilator is appropriately assisting the baby, allowing the baby to have its own respiratory efforts. Then we need to set the alarm limit of 5 centimeters of the Pmax. We need to set the apnea time of around 2 seconds. So we want the baby to breathe more frequently. We need to provide a P based upon the EDA minimum, and we need to keep the FiO2 to titrate the PaO to 50 to 60 or saturation of 80 to 92. And as we said, the trigger will be usually around 0.5 microvolts above the EDA minimum. And for every ventilator, as similar to even for a normal ventilation, the same or any kind of ventilation, we need to have a certain backup ventilator settings. So as soon as the baby disease condition is improving, slowly we can see that the patient EDA peaks will gradually fall under the 10 microvolts. Then you need to slow down the NAVA level. And we need to maintain the EDA peak in 10 to 15 NAVA levels. So first what we do is we decrease the NAVA level by maintaining the proper tidal volume, and then maintain the EDA levels in 10 to 15 microvolts. Then we increase slowly the apnea time from 2 to 5. All these kind of settings can be increased. Still we need to, and also we decrease the backup settings, and then we further decrease the NAVA level. So finally, when you come to very minimal NAVA levels of 0.5 to 1 centimeters of water, we can extubate the baby directly from the NAVA to the NAV NAVA, and we need to increase the apnea time to the 5 seconds. And then we monitor the EDA. So after extubation and coming to the NAVA levels, and slowly in the initial point of period, we may increase the NAVA level by 0.5 to 1 centimeters in order to have adequate amount of the tidal volume. So slowly the NAVA levels can be further weaned from 0.5 to 1 centimeters to 0.5, then to 0. And we continue to have this EDA catheter in place, and we provide this kind of NAVA with zero, we continue the same mode of NAV NAVA with zero NAVA. So the patient, so the ventilator is not assisting for any breath of the baby. There will be only CPAP being delivered to the baby, but still we are able to monitor the respiratory efforts and we are to monitor the EDA signal in the baby. So however, even though it looks so promising, there are certain contraindications that are present for using the NAVA. That majority of the babies in the term may be ventilated secondary to the HIE, where they might have an impaired respiratory drive. Sometimes the baby might have developed a stroke because of the perinatal stroke, or there may overwhelming sepsis that impairs the respiratory drive. The babies might go in frequent episodes of apnea, or sometimes we might be oversedate or paralysis for certain conditions, like in the case of PPHN, where the respiratory drive is impaired. Here it's very difficult for using the NAVA, where the application of NAVA is not feasible and it's more like normal conventional ventilation. Sometimes there are certain anomalies, like in a TEV for esophageal atresias or esophageal surgeries, where you cannot insert the NAVA catheter, or sometimes the phrenic nerve injuries can happen because of birth asphyxia or certain difficult deliveries, where your NAVA catheter, even though we have been placed, is not at all useful. Overall, the EDA catheter can help in monitoring the diaphragmatic activity based upon the EDA levels. EDA max, we can adjust the weaning process. EDA min, we can adjust the appropriate PEEP so that it helps in monitoring the baby respiratory effort and guiding the NAVA, so that overall the baby's respiratory effort is still maintained and we prevent the muscular exhaustion. so that we can have a proper extubation of the baby. The NAVA will, based upon the set of the NAVA, based upon the EDI, it provides the adequate respiratory support to the baby. So it not over-ventilate or under-ventilate, so the lungs will be protected, prevented from the villi, and your helps in the diaphragmatic activity to be in appropriate way, and it helps in the babies to early extubate. By providing a synchrony and providing a proper respiratory support, the quality of the sleep will be improved and the baby's weight will be increased. In a case of a NIV NAVA, where you can monitor the baby, you can have better synchrony based upon the baby's effort. We can adjust the baby's efforts. We can adjust the Pmax and baby, based upon this, we can maintain the normal tidal volume. And as this not needed to be fitted snugly, it is based upon the diaphragmatic activities, which is independent of the leakage, and so it prevent any inadvertent respiratory failure and inadvertent intubations. So because of using NAVA, we can prevent the excessive amount of tidal volumes and inspiratory pressures. We can prevent the villi by monitoring the patient inspiratory, maintaining appropriate optimal inspiratory effort. We prevent the asynchrony so that we can promote a normal synchronous ventilation. For all this thing, we can, by providing a normal synchronous ventilation, there won't be any fighting with the ventilator. So we will avoid the sedation and the neurological damage will be decreased, and in the way the babies finally the outcome will be benefited. Not only theory part, we have certain studies where the NAVA was compared to the conventional ventilation for improving the oxygenation. So the study done by Sandeep Shetty et al., where they have taken 9 infants with the bronchopulmonary dysplasia at a gestation of 25 weeks, was born at 25 weeks, who are at the median posting of 20 weeks, where they compared with the NAVA with as control ventilation. Their primary endpoint is studying the oxygenation index, which is the product of the MAP into FiO2 by PaO2. They found that by using the NAVA, they have the oxygenation index was lower by 28%, which means that the oxygenation is appropriate and they are requiring less FiO2 levels. Even the mean PAP and the mean MAP were significantly lower in the NAVA. That's why the MAP is decreased, so the oxygen index also decreased. The compliance was better in the case of the NAVA compared to the assist control of ventilation. So when compared to this NAVA compared to conventional ventilation regarding sedation, so there is a study where the 14 intubated preterms of around 27 to 35 weeks with acute respiratory failure were compared to NAVA with the pressure volume controlled ventilation. It's a prospective study where they are given a 2 hours of PRVC, then changed to the NAVA, and they found that by compared to the PRVC, the NAVA ventilation, the peak pressures were significantly lower. The tidal volume were generated for the lower, even though it is lower, it is appropriate, not going to the very high tidal volumes. And the babies who doesn't require sedations are much higher, and those are statistically significant. So in this way, we can find that this NAVA will help in decreasing the usage of the fentanyl, so thereby preventing the abnormal neurological abnormalities in the baby. So regarding the synchronization of the work of breathing, when compared with the NAVA with NAVA or CPAP, so there is a study by the Hookey et al. Where the 10 infants of around 1 to 22 weeks PMA, post chronological age with less than 5 kgs, in the post-operative period of the cardiac surgeries, immediately after extubation, they have been given either NIV NAVA or the nasal CPAP. And they found what they want is to know whether it is feasible to provide the NIV NAVA, and they want to assess the quality of synchronization of the ventilatory mode and its influence on the ventilatory parameters to assess indirectly the work of breathing. So by using this, they found that EDA signal and the correct placement of a NAVA catheter was very easy in all these subjects. And they found that NIV NAVA allows better synchronization. And by using the NIV NAVA, there is a reduction in the EDA. That means that the NAVA is adequately supporting the ventilation, supporting the work of the breathing of the baby, thereby decreasing the more amount of workload on the diaphragm and better improvement of the work of the breathing compared to the nasal CPAP. They found that by synchronizing analysis, by using the NAV NAVA, showed that the 99% of the neural trickling is there with very low inspirated trigger delay and is not being affected by the leak, even though the significant amount of leak is there. So to summarize, the NAVA is a proven and the newer modality of ventilation. It relies on the neural activation of the diaphragm from the brain and to provide the appropriate proportional amount of the respiratory assistance. By achieving the break point, we adequately provide the respiratory support, neither over ventilating or under ventilating. And this is not based upon our experience or activity, it's based upon the baby's requirement from the brain. So NIV NAVA represent an innovative way to synchronize. As we have seen, there's so much of asynchrony, even though we use adequate amount of flow sensors. during the non-invasive ventilation. But the problem, as we discussed, the cost of the EDA catheter can limit its use in current settings, and it's one-time use and maybe used maximum for 5 days. So NAVA, still we need so much of research in the NAVA. So in the future, the NAVA can be a better option for the babies who doesn't have any contraindication to the NAVA. With this, I conclude my presentation. Thank you.